Hello, my dear listeners. Welcome to Pulmonology Read Aloud with a fresh new series on obstructive sleep apnea. A lot of you have sent in your DMs to include OSA, the pathophysiology, the various types, the treatment, pediatric OSA. So I thought I should start a short series on obstructive sleep apnea with things that we would benefit you clinically. So today we'll be starting with the pathophysiology and endotypes of obstructive sleep apnea. This is a very important topic because the way we manage obstructive sleep apnea is changing. We're moving on from the CPAP only approach to a lot of more inclusive therapy. So it's important to refresh the pathophysiology and often also to clear the doubt that OSA is not always due to obstruction. So let's get started. So this is the paper, or rather, this is a very short document that I've referred to in today's video. I found this really interesting, the ATS Scholar documents on the fly. These are very brief, crisp resources to talk about clinical data, teachable items, and I did see an article on OSA, pathophysiology, and endotypes, and I decided to do a read aloud on this. It's a short document. You can read it in the 2023 ATS Scholar as well. So, obstructive sleep apnea, we know, is a very prevalent condition. A recent paper in India showed that the prevalence could be as high as 104 million in economically productive group. So it's very prevalent and it's characterized by recurring upper airway collapse during sleep. Now, when this happens, it will cause reduced breathing. So either there will be a hypopnea or a partial obstruction to the airflow or a complete cessation to the breathing, which is our apnea, which lasts more than 10 seconds. It can also lead, and it would rather lead, to nocturnal desaturation. It can lead in some people to hypercapnia, especially the obese, and sleep arousals. So, what are the endotypes of OSA? Now, we know with time that OSA is a very heterogeneous pathology. There are multiple possible causes of OSA, and this underlying physiological mechanism that leads to the clinical type of OSA that we see are endotypes. Endotypes are very valuable because they tell us what is the best treatment plan for every patient in OSA. And endotypes are also valuable because we do see a lot of patients where we do not suspect OSA by means of their build or just because of obesity or just because of an overcrowding of the oropharynx, and yet they do have an OSA. So, in such patients, we're able to explain better why this patient would have an obstructive sleep apnea. Now, amongst the currently accepted endotypes or pathophysiologies, there are four main causes. Number one is anatomical compromise of the upper airway. Number two is an unstable ventilatory control, also called as increased loop gain. Number three is a low arousal threshold. And number four is pharyngeal dilator muscle dysfunction. Now, how do we determine these endotypes and how have researchers come to the conclusion that these could be the various endotypes? This has happened by using mathematical analysis of the PSG data or through directly measuring. So this has happened over a period of time with a complex analysis of the polysomnogram and doing certain measurements like esophageal pressure and otherwise to determine the causes. Now, if you look at this figure, you can see the four endotypes of OSA. One is low arousal threshold. That means a patient who gets aroused or wakes up more frequently. B is unstable ventilatory control. So it's coming more, both of them are coming more neurogenically. C is the anatomical compromise. So this is the soft palate, this is the posterior pharyngeal wall, and this is the actual obstruction. And number four is pharyngeal dilator muscle dysfunction. So this is the forces that normally should keep an airway open but are unable to keep it open. So how is each endotype defined and how is it relevant to our treatment? Now, every endotype that is defined will determine what kind of manifestation the patient has and what treatment would benefit. If we talk about anatomical compromise, it means that a patient is anatomically susceptible to upper airway obstruction. So there is a reduced upper airway cross-sectional area and the arrangement of the soft tissue like the tonsils, the adenoids, the uvula, the palatal wall, the tongue is in such a way that the upper airway area is small and further lessens in sleep. Now, anatomical compromise can ideally be addressed with therapies like a CPAP, which will splint open the airway, or a mandibular advancement device, which will push the jaw forward, or surgical therapies. When we talk about any obstruction or resistance to airflow, something that we need to remember is the Ohm's law. Ohm's law says that Q, which is the flow, is dependent on the pressure gradient, which is the upstream minus downstream pressure, and the resistance inversely. So the resistance is normally constant in tidal breath to airflow, but the pressure gradient between upstream and downstream will determine how the flow of air or current be. So when we look at the human oropharynx and we go on to the lungs, the pressure in our oral cavity or in the upper airway is almost 0 centimeters of water relative to the atmospheric pressure. And the lungs are always at a negative pressure, say minus 6 centimeters of water to minus 30 relative to the atmospheric pressure. So the flow starts from 0 to minus 6, higher to the lower pressure. Now, when we consider the upstream pressure to be the nasal segment and the downstream pressure to be the tracheal segment, for the flow to occur, there has to be a higher pressure gradient upstream by increased nasal airway resistance upstream and a downstream pressure in the trachea where this will go. Now, in between, we have a collapsible pharyngeal segment. Now, if suppose the pressure here is high, there is a critical pressure, a pressure of the tissues, which in case is high, then the pressure flow from the upstream nasal to the downstream will be interrupted because there is a change in the relation of the higher pressure here. And this P critical will determine anatomical obstruction. So Pcrit is determining the degree of upper airway obstruction. It is that pressure of the lumen or luminal pressure at which the airway will start collapsing and the flow will not happen downstream. This is that mean closing pressure which will be high in patients with obstructive sleep apnea as compared to other patients. If, however, the downstream pressure gradient would have been more negative, there would have been some gradient, but here there is no gradient. So, P critical is this pressure that determines upper airway obstruction. The second one is the unstable ventilatory control. Now, unstable ventilatory control is also called as loop gain. Loop gain essentially represents that the respiratory system's sensitivity in adjusting the breathing in response to changes in partial pressure of carbon dioxide is much more. So, patients with high loop gain have exuberant responses to fluctuations in partial pressure of carbon dioxide. And so, they're not able to have a smooth breathing or a controlled breathing. So, unstable ventilatory control is an endotype wherein the neurogenic control in the respiratory center is affected and it's more sensitive to changes in partial pressure of CO2. So if you look at this, this is the pons in the medulla, and this is our pontine respiratory group, the pneumotaxic and the apneustic center, and through impulses from the accessory respiratory muscles, there is an impulse to these muscles and a response based on this respiratory center. If there is an obstruction to the flow, if there is a change in partial pressure of CO2, either we can have an oversensitive response with an exaggerated exuberant response and changes, or we could have a normal response. Now, in patients who have airflow limitation, in case there is a high loop gain, a more sensitive response, there will be more unstable ventilation, and this endotype can also have obstructive sleep apnea. The third condition is a low arousal threshold. A low arousal threshold means that the stimulus that a patient requires to waken themselves in response to a respiratory event is very low. So if there is any little change in respiration, the patient will undergo a arousal. And so these patients do not have sufficient accumulation of signals from the respiratory stimulus to activate the pharyngeal dilator muscles. It's been seen that a lot of patients with OSA have a low arousal threshold. So the stimulus to awaken them is much more. And how do we manage these patients will not be through CPAP, probably would be to increase their arousal threshold by giving them hypnotics. So you can see here that normally in response to any increase in intrathoracic negative pressure, there should be an arousal threshold at which the sleep cycle will be affected and there will be upper airway dilation. But in patients who have a low arousal threshold, there will be more instability and more erratic changes. So OSA patients have been seen to have a low arousal threshold in this endotype. So the other group that is there is the patients who have impaired pharyngeal muscle dilatory function. So imagine that those pharyngeal muscles which are supposed to keep the airway open are not able to open the airway. So when they are not able to keep the airway open, there's more collapsibility. And in this group, uh, by giving stimulus to these muscles, the activity in these muscles like the genioglossus, the geniohyoid, the sternohyoid, these muscles, tensor veli pelletini, levator veli pelletini, the collapsible tube can be kept open. So if this is impaired again, the patient tends to have an upper airway obstruction. So here treatments to improve the pharyngeal dilator function like electrical stimulation devices, like the recently developed impulse devices and neuromuscular electrical stimulation can offer treatment. So there are these neuromuscular factors, anatomical factors, central factors, and other factors that can result in obstructive sleep apnea. The author concludes that we still need validation and pragmatic implementation in softwares to determine these endotypes before we start using them, but it's important to identify them because that will improve treatment outcomes. With that, I conclude this video. I'll come up with another video of the OSA series very soon. Thank you and happy reading.